Now, when speaking about tumors, I'm going to focus on soft tissue tumors. They're a lot more common than bony tumors, and by a large amount. And when you're within soft tissue tumors, it's benign lesions far outnumber malignant lesions. And a lot of these lesions we don't even image. They present clinically, the vast majority being benign. In the general practice of radiology, you'll often be the first one to see these, and it's helpful if you make a standardized detailed report. You may also be following these after treatment. And so let's go through the things that we need to mention in a report for soft tissue tumors. We're going to start with location, and that means obviously what body part, but also what compartment it's in, if that's possible, especially if it's going from one compartment to another. That's absolutely critically important. And sometimes you'll see references divide compartments up, and that might be overly complicated. I think you can keep it simple and just give a general idea. Is it in the anterior, the posterior compartment? And this is done by looking at atlases online. The size is critical, of course. We want to measure the size in 3 planes, and I usually go for the largest because that could have implications for the treatment. For example, 5 centimeters is often a cutoff for when someone could enter a clinical trial or undergoes adjuvant therapy, chemotherapy or radiation. And so if it's around 5, I'll just go for probably over that. And when I mention the adjuvant therapy, keep in mind that surgery is the primary treatment for sarcomas. Site of origin. If possible, does it come from a muscle? Does it come from a nerve? Is it between muscles? Does it come from the fat? And that's helpful if possible. Borders and shape. Sarcomas often are well defined, so you cannot count on the shape. It is important to describe the shape, but you can't decide whether it's benign or malignant based on the shape. In fact, none of these findings are very reliable for benign versus malignant. We want to give a location relative to a landmark, and that's an external landmark that's palpable. Relation to other structures, and that's if in case it's invading bone or surrounding an artery, for example. Is it breaking through the fascia? The signal, the T1, the T2, does it enhance? Does it completely enhance? Is there surrounding enhancement, surrounding edema, tail-like projections extending along the fascia or from the tumor? What does the vasculature look like? Is there a lot of vasculature? Are there flow voids? Can you see vessels go to or from the lesion? Finally, we do lymph nodes, and lymph nodes are very uncommon to be involved in sarcomas. Of course, we have to look for them, but don't be surprised if you almost never see this. We'll go through the list a few times and then go ahead and focus on the lesions. Here we have a very large lesion in the posterior compartment of the thigh. As far as site of origin, I'm going to suggest that it comes from a muscle. I'm going to give the size in 3 planes. I'll measure it both in the AP, the transverse, as well as the cranial caudal. And like I said, I want to err on the side of larger. Sometimes they're hard to measure, and you just have to give your best estimate. The borders and the shape. The shape is important in this particular lesion. It has a kind of an odd shape to it, but it's almost ovoid. But I want to give the fact that the borders are mostly well defined, except for an area that's not. And I would say a small area posteriorly may not be well defined. Now, relative to a landmark, this case is so obvious that it's probably not as critical, but I might say something like it extends to measure to the level of the joint line of the knee, and you can also do that to the greater trochanter of the hip. It might be that they palpate this, but they still want to know how high it goes internally and may not be able to tell that. The relationship to the other structures, what is it doing? So I kind of look all the way around. I see that it's extending up to the fascia. Now when it comes down to relationship, and that is, for example, what's it doing to the neurovascular bundle, there's one thing that's critical, and that is an axial T1 sequence. If you don't do an axial T1 sequence, and that does happen, the surgeons that this patient is referred to, the ortho-oncology surgeons, get upset. You want to always do the T1 because they want to see the surrounding fat. And sometimes they'll do a T2 without fat suppression, which is okay. The main thing is to see that fat. I prefer the T1 because I can also evaluate for other things like blood and marrow. And you can see in this case it's extending to the neurovascular bundle. Maybe it's almost touching it. I always want to talk about fat planes between structures. And so, for example, here is the bone. And bones, by the way, have their own compartment, as do neurovascular bundles. And so this touches the bone, it looks like. So I'm going to go over here, and I'm going to go over to my T2, and I'm going to see that it touches the bone, and I don't see a fat plane. So I will describe that. However, I'll also mention that there's no edema in the cortex or the marrow. So there's no irregular cortical signal or marrow signal, and it's unlikely that that bone is invaded. And by that, what's more important is that it means that they can strip that off of the bone without having to take the bone. And that could be important when it comes to stability for fracture risk. Sometimes radiographs are super helpful to see if there's some remodeling in that location, but this is very helpful to look for marrow signal abnormalities. You also want to mention nerves, because nerves are often surrounded, not invaded as much as surrounded. So I use the term encasement or surrounding or abutting rather than invading. And there is a large amount of encasement that they can actually still save that nerve, especially for benign lesions which will wrap around and invaginate the nerve, and they will go ahead and take that out. So the word invasion sounds a little too aggressive. You even want to mention in relationship to a joint and tendons and everything really. They don't usually go into joints, but it's good to look for that. How about surrounding signal? Well, we want to look for any signal that is extending beyond this tumor. Maybe a little here, but not really. And then the same goes with enhancement. And those areas are going to be important for treatment. Here is an example. I didn't really see it on the axial, but I look over here, I see some increased signal intensity extending inferiorly. Now, is that just going to be venous structures? It's going to be a little tough to say for sure, so we're going to look on all our other sequences. Seems to like it goes down the neurovascular bundle, and that could be a problem. So we're going to just describe that there is increased signal extending inferiorly. Then we want to look and see if that indeed enhances. Here I'm bringing up another plane to help us, and I do see some increased signal here, so I'm a little worried that this tumor might be extending along that neurovascular bundle, or maybe it's just causing some obstruction, but I would mention it nonetheless. Now when we talk about vasculature, I generally will look all around for some major vessels going to the lesion. I'm not going to describe every little one. And then I don't see any flow voids in this lesion. So I would just probably say that, or you may not have to mention it if they're not there. Finally, we talked about lymph nodes. And of course, we don't know if they're lymph nodes distant, but we can look within the field of view. And within the field of view, we see a few scattered lymph nodes, but we don't see any lymphadenopathy. And again, pretty rare thing to find. Here's a vessel right here, so I probably want to describe how close that is. I think we talked about that earlier. So as you scroll through here, you start to see different things, and so it's important to say all of that. I just noticed also this superior little bit of tail peritumoral edema up here, and I would mention that. Sometimes these lesions will extend along the fascia, and that'll also be something that's very important to mention. And I suppose it's helpful to describe, to tell what this lesion is, and this turns out to be a myxoid liposarcoma. And when we talked about imaging characteristics, I didn't mention that I do see a lot of heterogeneous signal here, and you can see some foci of increased signal intensity, and those could be one of two things. Those could be fat or hemorrhage. And for this, I'm going to bring up the T2, and I can see that a lot of those areas tend to drop out, and so I think those are small foci of